Ladies and gentlemen, hello. Fire off. My name's Sebastian Morgan-Lynch, Health Policy Advisor for the Privacy Commissioner. Let's leave it open, shall we? Open, inclusive. The spirit of the times. This is talking about shared care, electronic health records and related things in the context of privacy. Obviously, where I'm starting from is privacy, because that's my kind of thing. Please come in, have a seat. Have a seat. I've got 5 minutes to do a spiel. I've been firmly advised. So I'm going to talk very fast, hopefully cover off some issues, put out some questions, put out some answers, but mainly put out some questions. And my main thinking is to maybe define some of the problem around shared care records, around electronic health records, around privacy, around where we are at the moment in all these spaces, and also maybe cover off some frequently asked questions about privacy, so we're starting from a shared point of reference. So why electronic health records? Why do we bother? Frankly, because everything's getting more expensive all the time. If you look at healthcare around the world, it's going up like that. If you look at how much healthcare is costing, it's going up like that. At some point, those two lines are going to cross where they haven't already. So you've got to do something to the slope. You've got to bring the cost down. Electronic health records is a way of doing that. So that's sort of the basic reason. But it's really hard. It's a really, really hard thing to do. The UK, as I'm sure most of the people in this room will be aware, basically wasted £12 billion setting up an electronic health record that has not really measured up, hasn't really done what it's supposed to do. £12 billion, there's a lot of smackers, to be sure. So, questions. I've got 6. What is privacy? Who can see your health information? Do you get to say when your health information should be kept secret? Who owns your health information? How long is it going to be held for? How will it be protected? And it's probably that last one that I'll, I guess, throw back to you people, but any of those can be challenged. So what is privacy? Everybody knows what privacy is. It's the right to not be spied on in your backyard, and that in fact was how it started back in 1890. A lovely couple of fellows called Brandeis and Warren had a party. Some journalists climbed over the wall, took photos and wrote down. They were outraged, so they wrote a learned law journal article creating the tort of privacy. It's a beautiful piece of writing, actually. It sort of waxes quite eloquent and is quite relevant even today. However, that's not where we're at now. What privacy is now is the ability to have some control over your personal information in the face of technological developments that lessen that control. That's where it's at. So it's an outgrowth of all that. It's that sense of the ability to control information is skyrocketing. What do we do about it? And that's where, I guess, my final question will direct us. But just hold that for the moment. In practice in New Zealand, it's the Health Information Privacy Code that regulates privacy. 12 rules. Rule 1, only collect the information you need. Rule 2, get it from the person concerned. Rule 3, tell them what you're doing. Rule 4, be nice when you're doing it. Rule 5, take care of it once you've got it. Rule 6, make sure people can access it if they want to. Rule 7, they can correct it if they want to. Rule 8, make sure to take care of it before you use it. Rule 9, get rid of it when you're done with it. Rule 10, only use it for the purpose you obtained it. Rule 11, only disclose it if that's why you obtained it. And Rule 12, be nice with unique identifiers. So that's privacy in a nutshell. Obviously a crude summary, as such things always are. Who can see your information? This is where it really gets interesting. Because you think, well, okay, it's my information. I should be able to, I should say. But do you want to be constantly contacted? You know, can so-and-so, can Dr. Jones see your information? Can the secretary see your information? Can the nurse see your information? No, you don't. So you sort of, you say, okay, well, I'm going to the hospital, so basically hospital people can see my information. But then the ministry says, well, we want to better spend our money because healthcare is expensive, so we want to see what the hospital's doing. Is that okay? And you go, well, it's kind of the same kind of thing, so yeah, that's okay. But the nutshell is there are very broad constraints around who can see your information, and I think getting your head around those is a really good starting point. So if you've given permission, it's always okay. If you've been told ahead of time who is going to see it and why, it's okay. If someone is providing medical care to you, or they're going to, and they've asked for it, it's okay. And that's without even coming back to you. So in that last one, I think we're already stepping a little bit away from people's intuitive understanding of what level of control you have over your personal information. And that kind of brings me to my next point, which is, do you get to say when your health information should be kept secret? Because there are certain, I mean, obviously all information's controlled by privacy. All health information is confidential. But there, on a practical level, some kinds of confidential are more important than other kinds. Sexual information, sexual health information, information about drug use, information about mental health. You put those at a slightly higher level of confidentiality. What level of control do you have over it? There's no blanket veto right over information. That's, I think, an important thing to hold on to. You can't say this must never be seen by anybody and have that statement be given legal force. It can be taken into account, it can be relevant. Excellent question. You can ask for information to be deleted and a decision has to be made, but no, you don't. There's a right of correction, and that includes deletion. That's that 7, which I was past, Rule 7. But you cannot require that something be taken out when it's... You can have your point of view put on the file. That's the sort of the scope of the right. Next question, who owns your health information? The obvious answer is I do. It's my health information. It's right there in the phrase. But in actual fact, ownership is a kind of funny way to look at it. Come on in, have a seat. Because if I own something, I own my stupid cell phone that I hate, I can throw it away. I can throw it in the sea. I can smash it with a hammer. I can put it in a locked box and nobody can ever see it. None of those things apply to information. I don't have rights that are similar to that in respect to my information. I can get access to it. That's a right. I can ask for it to be corrected or deleted. That's a right. And I can make a complaint about breach of obligations. So it's not the same thing. So it's not so much that it's right or wrong to say I own my information. It's just that it takes the discussion down the wrong path because you end up with a whole bunch of assumptions about ownership that don't actually match up with the law. So that's my kind of package spiel about ownership. Nearly at the end of my 5 minutes. How long is your health information going to be held for? This is relevant as we move into electronic health records discussions because, as we all know, storage prices are going down. The computing power of computers is going up, and that's never going to stop, ever. I'm going to make a call there. So it's always going to be cheaper and cheaper to store stuff, and it's always going to be easier and easier to collate it. So all the information that we're creating now will be around 50 years from now, assuming no global collapse. As Bruce Schneier brilliantly said, we're embarking on a great global experiment of never forgetting. And that's relevant when you talk about electronic health records, because although there's a sort of a weak provision in the Health Information Privacy Code to say you should only hold onto information as long as you've got a purpose, it's not that, it's not really big stick, or you could attach to it, because you can say, well, we need it for, in case this person gets sick in the future, or we need it as a record of care, or we need it to protect ourselves in the event that there's a complaint brought against us. And once you get past death, then, the arguments change, but enough on that topic. So basically, that's going to be held on to for a long time. Absolute minimum 10 years, probable minimum 20 years, practical minimum forever. And last question, or set of questions, how should your information be protected? Because we've got this health code, we've got these privacy protections. They say you've got to have purpose and openness. There's got to be a purpose for holding information, and you've got to be open about that information. But that doesn't actually take us that far. Because if you say, okay, well, I went to my cousin in Putaruru, and she's a GP, and then there was my sister-in-law who was the nurse, and then she told her husband about this, and how do I know where that information went, or how can you be sure of that? The health code doesn't answer you. And there are a few kind of metaphors for protections, and one's a security camera, as we embark on the grand experiment of never forgetting with electronic health records, where every interaction with an electronic health record is recorded. Now, that's good in some ways, and you didn't get it with paper files. My mother was a practice nurse for 40 years, and she had all her patient files. Just, nobody could tell if you'd pulled out the manila folder and leafed through it. Not the case with electronic health records. So that's an advance in some ways, but somebody's actually got to look at and care about those security camera records. So that's one possibility, security camera. Next modifier of that is what I call the speed camera, where certain actions trigger an alert. Now, that's a bit better because you don't end up with 1 million billion hours of footage that nobody's ever going to watch, but at the same time you still have to have somebody behind it governing. You need governance around the information. Next option is the locked gate. You can only see it when I have given permission. Now that's the greatest level of control, but is it actually practical? Again, do you want to be constantly bothered with essentially trivial decisions? I mean, one of them in 1,000 won't be trivial, and that's the one you want to know about, but are you going to have every single decision being taken to you? And finally, an option is the break glass, where clinicians only see what they need to see, like if my GP can see my records, no other GPs can see my records, but let's say I'm in an accident, then emergency room clinician can break the glass. Say, okay, well, this is why I need to see it. The record goes on a special list, so it's got aspects of the speed camera, and that can then be reviewed. Again, it's not a bad compromise, but it does need governance behind it. So that's my 5-minute spiel. I'm going to ask Chris and Eve, awesome assistants, to carry mics round and throw it open. And I'm going to ask... Oh, Sue. Yeah. Microphone in full effect.
Hello?
Hello.
Oh, yes. There's going to be an explosion in genetic information. We really don't understand that in New Zealand yet. But is there going to be any special provisions around personal genetic records? Because that's obviously going to be of interest, and it's going to be a lot of data.
I've got one comment on that, which is in relation to the Guthrie card. The Guthrie card collection. Is everybody familiar with Guthrie card collections? Newborn blood spot samples taken at birth. There are currently 2.2 million of them sitting in a warehouse in South Auckland. They're going to be held forever. So it's a blood sample for basically everybody in the country eventually. Now, they've always just been kind of held because, and a decision was made to change that, well, just because, to actually say, well, we're going to hold on to them in case we need them, formally in case we need them. So we're actually in the process of putting out a code restricting those uses that can put to that the uses of information derived from blood samples taken from the newborn metabolic screening program. So that's one aspect of it. But more widely, I think there's the sample itself, which has, I guess, cultural value and personal value, and there's the information derived from it. I mean, in a sense, a DNA sample is just information. And so any use of that information is then subject to the health code. You've got those protections. But I think the actual work on the implications of that explosion of technology is probably going to have to wait until we find out what it's going to do. Yep. Yeah. Yep. I mean, there's a bunch of things you can do with genetic information. You can establish persons' trays. You can establish the trays of people related to them. And the level of control you have over that is basically zero once it's been tested. So there's not a way of controlling the gene once it's out of the bottle, but there's not also there's not a way in which it's completely distinct from other kinds of information about yourself, like your blood test results, genetic information. That the main distinguisher is that it's about your family as well. So.
The other issue with genetic information is that there's a whole heap of tests that you can't do at the moment.
Yeah.
But if you hold the information, you can post-test for them later.
Yeah.
And a lot of that has to do with what are the risks of particular conditions arising in people's offspring and things like that. So is it ethical to post-analyse the genetic information that you collected from granddad's umbilical cord prick in 50 years' time, when the test is presumably developed to the point where it's not a 50-50 false positive anyway, to enable little Jimmy to potentially change his lifestyle, or the Big Brother thing would say to enable somebody to make decisions about what level of education you're prepared to pay for little Jimmy because of what happened in granddad's blood.
With the blood spot cards, the solution we've got is that you need permission of a close available relative to do that kind of analysis. So that's not a perfect solution, but at least it's something that involves the closest person to the possibly deceased dead relative. I've been talking a lot. Somebody
My question is about ownership, really, back to ownership.
Yeah.
I understand, I follow your line about me not owning my personal information, albeit that I might like something stronger to fill in the gap somehow or other. Because the questions you asked, you can pop it in a box and throw it, lock it and keep it like that forever. You can throw it away. Somehow or other, I feel that those are not dead questions simply because the way the law handles information, my possession of whatever, of information. But the second thing is that I feel that people who hold my information about me have something which is much closer to ownership. They certainly can trade it, or appear to be able to. They can put a value on it. In some respects, if I can't own it, how can they? And certainly, and hold it for long periods of time. I mean, you mentioned the very weak disposal provision in our Privacy Act, and what the woman formerly from the FTC said this morning about the huge silos of data that Google owns. I mean, there's a question really about the value, the true value of that, its accuracy, and whether or not seriously ownership of that to trade and to sell adverts should be very severely curtailed. I mean, stuff thrown away. I mean, Germany has held Google much more to account about how long it keeps data.
There's the famous quote, if you're not paying anything, then you're the product that's being sold. That's in relation to sort of Facebook and the like, and I think that's very sound. I'm taking that point back to health information. I think there's a really large looming question around whether, what happens to the bodies of information that will be built up. If I'm a health agency and I'm selling out, can I chunk a bit of it off and sell it to a PHO or another DHB? How does that work? It's a bit of an open question.
Hi, I'm Michelle. I'm a nurse, but also a consumer of health services as everyone else is. If you're going to hold my health data, I'd like you to hold it for my whole lifetime. I'd like it to be a cumulative body, because then you're going to be able to, the health professionals who are caring for me if I get sick in the future, when I may not be able to speak for myself, where my memory may not be correct, will be able to provide me the best possible care. I want them to remember that there was an antibiotic I took yonks ago that gave me bad side effects. I don't want to have that again. So I want you to hold, I want it to be held, I want it to be held securely, and I want it available when they're prescribing me another antibiotic or whatever else it is.
Yeah, and that's absolutely one of the big drivers. The other big drivers for electronic health records, apart from the slightly cynical cost side of things, is that it actually just can work better. If you break your leg in the North Island, you live in Christchurch, then you want them to have your allergies and things right there.
Yeah, and in the future, excuse me, I'm on holiday in Australia and I break my leg, I want it there, or in the UK, or anywhere else. We've got a global village.
Yep. Absolutely.
And I want that available so I get consistent care no matter where I am.
And that does bear on the point you were making before about deletion.
At the moment, I've got my memory and I've got it all written down. I keep my own record. On the other hand, why do I have to keep my own record? If I could actually access the health record, I could have it that way. Why should I have to trust anybody else to keep my record if I can?
I mean, that kind of moves us on. Moves us on to the idea of the patient portal, where you can actually access it and control it, and it's something that is enormously attractive, particularly from a privacy point of view. So if we're talking about purpose and openness as being the key drivers of privacy rather than absolute control, then being able to see for yourself who's been seeing it, why they've been seeing it, to see it. You don't have to go through a process and right away, but you just type in your login, put your thumbprint or whatever, and bingo, it's there.
Well, we do that with our banks at the moment, don't we?
Exactly.
So banks hold our personal financial data, but if you use something like Xero or Mint, then you actually get information about that data that allows you to make decisions, and you're not using the person that created it.
There's two differences. One is that a bank is one entity, and that the other one is that they have to wear all the stuff-ups. Whereas I think with health, it's a million different agencies trying to share a similar kind of set of sets, and who actually pays the price if it all goes wrong? I mean, just those two distinction marks.
But I use multiple banks, and I use something in front of the multiple banks. So I think there are some similarities, especially when you start to think about who holds the data and who do I trust to hold the data. And I may be using a New Zealand bank, but when I access the interface, it might be in America, and suddenly privacy and where that data sits is important. But I think what's more important is that the reason that I use the other service is that I don't get what I want from my bank. And if my bank provided it to me, then I wouldn't use the other service. So for me, if we look at some of the trending statistics in society, the ageing population, the cost of healthcare, if we don't make these types of services and the data available to people so they can be accountable for their own healthcare, we won't be able to sustain a healthcare system into the future. So I think when you start to look at cost drivers, making people accountable for their own healthcare and having a system which is designed to keep people well rather than address the needs of somebody when they're ill, technology is probably only one of the most sustainable ways to do that. But if you take that even further and look at some of the challenges we have in the gap of internet and, I guess the digital divide, the lack of broadband in the senior sector, for example. I think the last household labour force survey was 2009, and the penetration rate of broadband in seniors was only 25%. So we can give a mobile device or a St John device or a device to somebody in a scenario where they're responsible for looking after themselves to monitor them, but if they don't know how to use it, then there's a whole education process that's also got to go on around that in order to make that healthcare in the home something that's viable. So the technology can be there, but if we don't have the broadband and people having the adoption of the broadband, then it's still not feasible. So I think there's a range of challenges that we need to address when we start to look at health information. It's the accountability of where the data is, making that data useful and ready, and being able to be purposed by the people that need it to look after their own care, and then making sure that the people that need it most get the most support in order to make it viable.
I think that's a great comment. I'd just add the importance of trust. Because we do regular surveys, and something ludicrous like 98% of people trust very much the health sector to hold their information, which is it's absolute top of the heap. And that's based largely on personal relationships. And so when you turn that into an electronic relationship, when, let's say, anybody who's a health practitioner might be able to get access to an electronic record, it's 150,000 people, what does that do to that relationship of trust? Because it's implicit right now, but when a huge level of trust is proven to be based on shaky footing, you don't feel grumpy, you feel betrayed. If a used car salesman, cheats you, it's like, okay, if a lawyer, yeah, whatever. But if something to do with your health betrays your trust, that's quite a different procedure. And I guess that's sort of something that needs to be kept in mind as well as the good points you're making.
I'd like to be very challenging now.
Do it.
So we trust our GPs, but we only go to them when we're ill. Shouldn't we, if we trusted them, and this is not, I'm not trying to be belittling of anybody as well, okay, but shouldn't we be in an environment where we have a constant relationship with our health practitioners so that we don't get ill in the first place, and wouldn't that create a better trust?
Yeah,
okay.
Sure.
Now,
but how do you get to that nice place?
I'm in security and I work in the health sector.
Yeah.
So, is this perceived trust that we have with our health practitioners, is it actually real or not, is a whole other story.
You can draw a parallel with, you hand your credit card to a person in a restaurant and they take it off, and you trust, or you put it on the internet and you trust. There's a huge amount of trust which is not actually founded on anything, but it feels like it's founded on something. And yeah.
I heard China funds GP services, so primary healthcare services on keeping people well. So instead of, we have a funding system where we pay and the government pays the doctors for sickness service when you see somebody. So if you put the funding the other way around, where if you keep people well and they don't need service, then maybe if we just change the whole funding round, we'll get more of a health-based service rather than a sickness-based service.
Yeah. There's a bit of that stuff with the sort of preventative funding for preventative stuff like COPC. Yeah. Hello.
Something that's occurred to me from the very beginning of what you were saying is that that the data should be kept as long as it's useful, as so weak as to possibly be meaningless. Like, because you could always find a reason why it's useful, even statistics or anything. And you could get, I mean, if you kept all the data on all the people, then you could correlate it in a way that could be really useful. But it also sounds like a massive potential loophole situation. Just like the human element in the data, who's the governance like? Is the governance solid? Is it going to be leaked somewhere that is not good? You know, is there going to be a corporate weasel that gets in there and starts making a whole lot of money off some weasel data? Yeah.
And as you hold more and more information in a more and more electronically accessible form, its value goes up over time. And this, as you say, you can collate it, you can analyse it. You know, if it's all in HL7, which is sort of the medical computer language, you can do an awful lot of clever stuff to it. And the temptation to have bad actors come in and grab it increases, on the ability to get to a particularly damaging piece of data about a person gets higher and higher. So the need for governance is ever growing. The Ministry of Health's got some, or the National Health Board's got some first steps in that direction, which is good to see, but still very much early days.
Can I just make a quick comment?
Oh, sorry, I didn't see.
Last week I met Richie Paulson down at Otago University, and he, of course, is doing the Dunedin Study, which is 1,000 people, and they're up to year 38 now.
Longitudinal.
Sorry?
Longitudinal?
Longitudinal study, yeah, it's called the Dunedin Study or the Longitudinal Study. What was surprising and interesting to us who were in the room when he was talking about it was there are a lot of privacy considerations around the study, and he is not going to budge on any of those things because the integrity of the study relies on it being very personal and very private, and what they do is they go to great lengths to actually bring people from all around the world to actually take part in that study. And so if you are looking at policy making or looking at global issues, and you can say this particular study is a landmark study in global terms, in fact, when it was started they said we're going to look at X, Y and Z factors. Now what's happened because of the explosion of technology and other disciplines and new knowledge, more people have come in on that study and they're looking at it from lots of different angles, but what's actually remained standard and locked down is the privacy, and it's the very privacy of that particular study that actually makes it so valuable. I wonder if you had any comments about that type of study.
I mean, in general, when you give your permission to have your information used in a certain way, then that's fine. I mean, I will say that whenever function creep becomes an issue, it's always for a really good reason. I mean, we have a lot of schemes, agencies come to us with schemes with saying we want to get this data and it was for this, but we actually want to do this, and this with it. And without exception, they're all extraordinarily well motivated. And it can feel kind of like you're a jatterbar in the way to say, well, no, you need to either go away and think about it again, or that's going to present real problems, or it's going to breach the trust of the people involved. But that's sort of privacy's role. It is to slow things down. It is to say, privacy has a value. People's trust has a value. The statements that you made when you set out actually have power, and they have to have power. Otherwise, you wouldn't be where you are now. We're looking to find these extra uses for the information. That's sort of.
If I can ask a question. Privacy of data is one aspect. My question is related to the accuracy of the data. So what is being done in the health sector to ensure that the human factor, to ensure that the data is accurate in the first instance, is going to be addressed? I'll tell you a story. I have identical twins. Turn up to triage at the hospital, and it was just through the pure good fortune of a switched-on receptionist who actually asked me to check and make sure that they were dealing with the right person. So I'd be interested to know what progress is being made in that regard.
I've got a friend at the ministry who had somebody with the same first name, same middle name, same last name, same town, and same date of birth, different one day. And they're constantly being kind of mistaken for each other and then swap back and swap back and swap back and swap back. I mean, as you get down to the 0.0001s, mistakes will be made. I don't think 100% is feasible or practical. I do know they are taking the National Health Index system, which is a robust bit of 70s technology, and bring it a little bit into the 21st century. So that's going to help in various ways, which could go into, but it gets fairly technical. It's probably a bit beyond the scope of the discussion. But I think that's another aspect of electronic health records. Things like scanning drugs before you administer them and when you give them to the patient. I mean, there's some crazy numbers around how many people die of medical misadventure. Yeah. 30%, I think, that's crazy numbers. And it's absolutely going to help with that. Of course, technology brings its own problems. And to an extent, it's a matter of perception as to whether, this technology did this and this and this. But actually, what are you comparing it with? Are you comparing it with, the worst of how things were without technology? Or, is it apples for apples? So I guess a constant battle. And electronic health records will help and hinder, but hopefully help more than hinder. Is that Weasley enough? It's a bit Weasley. Hey, Jim.
I'd like to just to go back to the question of trust, and I was a little bit concerned about the idea, both ideas really. I mean, incidentally, not to push the finger at you, but from health professionals and questions about privacy and policy and economics, and when they all come together. One of the famous mixes, really. I'm not convinced that health professionals are right in predicting Armageddon around older people and the health needs to the system. I think that's highly questionable. But it's a view often held by health professionals, and I suppose I can use you as an example. And the second question, the second issue is like China and primary healthcare. Again, keeping people well. China has very poor welfare services and very poor health services in general. You concentrate on keeping people well. You can start manipulating health service provision to ignore the people who are sick and let them die. There is an overlap there between older people and generally the sort of pursuit of health. And in that mix of disputable policy discussion, you throw in privacy. And then the question of trust comes up. I can quite easily say, well, I actually much prefer you didn't have my personal information. You might kill me off as an old person as no longer being worthy of care, in the basic belief that for the good of society we can't afford you any longer. And two, I don't want to be just any old person wandering into a place and decide that, well, because I'm sick, you're going to fiddle the statistics by ignoring me and presenting the local population as far more healthy than it is. Again, privacy pops into that one. Again, a question of trust.
Yeah, I mean, just one point about the wellness. I mean, I think what we've seen in America recently, if you've been following that whole thing with the Affordable Care Act, in America, because there's health insurance, a lot of people use the emergency room as the only place where they can get treatment. That's an extraordinarily expensive way to provide care. And a much more manageable way is to actually keep people well and have them go to their primary physician. So that's sort of one of the goals of the Act. I think that is that wellness, thing made manifest. You try and stop people at the top of the cliff.
I've got a question.
Yeah, sure.
Do you think you'll be a judderbar? You probably enjoy being a judderbar, I'm not sure. But do you think you'll be a judderbar when I want to take my health information and I want to actually let somebody else look at it? Not necessarily a doctor, but I want to be able to give my information to an organisation who will then take that medical information and present it in a way that makes it easy for me to understand what the heck's going on. I want to be able to compare myself with my other peers and look to see how I'm doing in this certain age group, in terms of cholesterol or weight or whatever it is. And I want to be able to take that information and to be able to manage it myself so that when I can go and organise tests of my own without having to go to a doctor, and then see that if I'm tracking okay, and then if I'm not, then to go and see the doctor. Do you think that's a reasonable outcome?
Yeah. The place where we'd put the judderbar, if we're going to go with that metaphor, I quite like it, is probably in front of the organisation setting up that scheme to say, well, have you thought about, who else is going to see the information? Have you thought about, what purposes you're holding it for? Have you thought about security? How are you going to hold it? Is it going to be offshored? Have you thought about how you communicate that to you or, your grandparents or your children? Because that's a key point, is that we've got all these, excellent goals and schemes, but how do you get them across? The average GP consultation lasts 8 minutes, and presumably most of that time is going to be spent actually, providing healthcare. So how do you transmit information about all these elaborate things that are going to be going on with health information? How do you be open about the information? That's probably where we'd focus. To say, well, have you considered the privacy impacts of what you're doing? Have you analysed those? And how are you going to put them across? But as far as you can do what you want with your information, that's not something we'd go anywhere near. So it's really just the agency that we're doing the comparing that we'd look at.
If you can get it. Get the information all the different places that it is currently.
You've got a right to get it. That's very strong. Any information about you can get from anyone with very, very few exceptions. Hello?
That does raise a good point, though, is that who's accountable for the consequences of you managing your own information? A lot of this stuff isn't about the technology, it is the governance, it's the ongoing stewardship and who's accountable for healthcare. There is duties of care in the health system that make it very difficult to manage because the doctors and people have a different legal relationship with you than, say, the CEO of the health board who they are employed by. It's one of the reasons why health is so hard to manage as a sector. But you can imagine the potential consequences if I decide to withdraw all my information from the system and then I do something that causes harm to me or to people around me. Where do the legal relationships lie? And because we're only just starting to nut some of that out, it's really important that we get the governance systems in place early and strongly so that all of the right voices are at the table. And frankly, at the moment, it's mainly clinicians driving that change process amongst themselves. And it does put rather too much weight on their shoulders, I think, because there's a whole lot of expertise they don't have. There are some big clashes at a population health versus individual health level. That stuff around how does my health compare with other people who are like me. All the people who plan the future of the health system want that information. Whether or not I want to give it to them, there's some value for them in knowing some aspects about me and my journey through the health system. So there's a lot of stuff that the technology actually makes it easier to see afterwards what people have done, but it doesn't stop it happening. And people present a lot of these conversations, these privacy conversations, as quite black or white. They're not. There is no such thing as a safe kind of system for storing that kind of information. It does get very touchy with health because it is deeply personal and because there are some quite severe social consequences for people of having, say, medication for mental health or sexual health encounters and stuff available to people. So there's quite a lot of effort that Sebastian and others are putting in now to resolving some of those issues. Like, how do you make sure that people who are working with you to help you manage your health only see the information that they need to see at the time. There are some aspects where having electronic health records are actually safer, because it's easier to hide things than it is in a paper file. Anyone who's seen paper files being passed around in a doctor's surgery or something, anybody can grab them. So there is actually potential to protect some things, but that's not built into the way the software is implemented. People actually have to make decisions that are human decisions about why to do that stuff. So it's good that we're having this conversation, but you'll see a lot more of this over the next couple of years.
Can I just ask the gentleman who wants to send all his data somewhere for all these tests? So in this context, is the health sector preparing for this? Is the health sector preparing for people who are going to go and send their data to someone who you actually have no idea whether their tests are valid, whether the information you're going to get back from them, are you sending them to a quack or are you sending them to somewhere legitimate? And is the health sector taking that into account? And if that data will then be brought back, what will be done with that?
I should just note that I can't take my information out of the health system. I can get a copy of it and do what I will with that. But
and then deal with the consequences of the...
Absolutely. Yep.
Okay.
I mean, your real options are you can get access to your information and you can decline to provide it. The idea is that you're told what's going to happen with your information once you provide it, then you make the choice about providing it in this ideal world of perfect informational autonomy, and then you can get access to it and find out, who's seen it and what's been done with it after the fact. In practice, of course, you just sign your name on the PHO enrolment form and then go and talk to your doctor about your bunions or whatever. So it's actually it plays almost no part in the lives of 99% of people. I would hazard a guess, but when it is important, it is extraordinarily important. So basically, it doesn't matter until it does, which is the worst kind of problem to have. Yeah.
So, yes, to clarify that, I didn't imagine that my records would be taken anywhere. Well, what would happen is that I would let people have access to the information within inside the system, and that they will just represent that information back to me. And so I'd let them do that. Now, the reason I want that is because we have this crazy situation at the moment. Let's say the GP asks me to go to do a lab test. Well, I'll go and do the lab test, but I won't know the results of that lab test for 6 months later until I go back and see the GP. And I just happen to ask, what was the lab test results like last time? By this time, it's 6 months old. And I don't get to see it. Surely I should be the one to kind of see, it's around about the same time as the doctor. Now, it'd be a bit different if we're talking about situations that are serious, but if we're just talking about just the general monitoring of health, then I think that that's entirely appropriate for me to be able to see that at the same time as the GP.
There's ongoing projects at the moment. There's Patient Vitals, which has got that kind of test information on a national level, and then there's sort of shared care when you've got kind of ongoing like maternity or long-term conditions. They're all sort of separate stores. So that the way it would work would be there is a sort of a central or a regional place where that data is held, and you can go to it via a patient portal.
The other thing that just crossed my mind, just while I've got the microphone and I can keep talking, was I know we've got to prepare for this, and I know there's lots of questions that have to be answered, but the question I have in my mind is when is enough that we can actually do something? Because there will never ever be a system in place that will meet every single potential scenario. And we do run the risk that we keep talking about this and we'll be here, 20 years down the time. We're sitting back here in this room. Some of us may still be here. And we're talking about the same thing. So at some point we kind of have to say, well, this is good enough and let's get on with it and solve the rest of the problems along the way.
Yeah. It is happening right now. I mean, don't get me wrong. It's nobody's sort of holding back going, if only we could make everything perfect in a privacy sense. There are lots and lots of projects on the national, on the regional, on the sort of local level. Joe?
Sebastian, I guess what worries me is that decline to provide provision, because at the moment the changes to Right 17B of the Health and Disability Code mean that someone else can decide for my information to be used without my knowledge or consent. And I think that watching what's happening with ethics committees at the moment and the downgrading of them around facilitating research rather than protecting patients, and also the fact that information is knowledge. You know, the health is one area where there's lots of Machiavellian motives. You know, like I know what I'm doing. Trust me, I'm doing it for your best and your best wishes. And should it actually be too arduous to ask you for permission to do that, then I'm doing it because it's for the public good and it's going to make you and the rest of the population better. And health, I think, is the area that operates in extensively, and I just wonder whether you've got any comments to make on those kind of issues, because I think, you know, with international pharmaceutical and with our industry, it has already got a bad history of using health information in that way, yeah, and also the use of genetic information in that way around genomes and things is also opens the door for some wide commercial interests to start getting their mucky hands in, and I guess I'm quite concerned about that.
Yeah. There's a broad exception around the use of information for research, as you know, that's been approved by an ethics committee. So in a sense that's in the code and in the Privacy Act. So in a sense that buck's been passed. Could it be passed back? Yes. Currently there are no kind of plans to do that. So I guess that's...
Not to sort of plug the next session, but health is social. And I think something that we forget about technology is that it's a tool and that it's supposed to provide connections and create stronger relationships, stronger networks, and loosen up the hierarchies that exist within the health system. I mean, so many problems that come out both as a consumer and a clinician all comes from the fact that we've got siloed information that isn't talking to each other. And the siloed information may be protected in some cases and sold in the others. And I think it's really important to remember that transparency doesn't work against privacy. And I'm concerned that we're sort of connecting openness to be something that's sort of a grab-all rather than that's something that's monitored and taken care of and held up to social accounts. So I just like to remember that health is social, and the fact is that we are accountable with the health decisions that we make.
Yeah, I guess the thing with siloed information is you may want it to stay siloed. You know, that's sort of, we were thinking about this around the health identity, the NHI revamp, and looking at the circumstances where you just really don't want any information about yourself to come out from this national record. So when you've got, when you're in women's refuge, when you've got, you've been getting care for a drug addiction, things like that. And so you can separate out those, but there's also a whole swathe of information that isn't what you call intrinsically sensitive, but just because of the fact that you were in a place at a certain time, that's sensitive, almost transactional information. And that's the nub of privacy. Almost the stuff about that's really facially, obviously confidential, super confidential is one thing, but it's the you know, situationally sensitive stuff that makes the really difficult dilemmas.
For transparency is so important, and the idea of who's accessing what is part of that, right?
Yep. Yes, and that's something that electronic health records absolutely can do. Hello.
So, if people want to compare themselves to the national average, but people also have the option of opting out, is there the danger that the data, the national average, might end up being skewed because certain groups of people take themselves out?
As a very, very crude rule of thumb, when you give people the option of opting out, very few people do this kind of situation, like, you know, in the 2-3%. But depending on the circumstance, that may or may not be a problem. Yeah, well, whatever, you know, it's as of right, that sense of, hang on, should I actually be able to say, no, I don't want to partake of this as of right? And that's a question that I don't think has been answered. I mean, legally, no, you don't. You can't say, you know, I don't want to, except by never going to the doctor. But you've got an NHI. The moment you go to a doctor, you've basically got an NHI. You get the sign of birth these days. That's true, yes.
There's already private sector opt-out.
Yeah.
If you go to a private hospital, your treatment information is not fed into the public systems necessarily, because the public system relies on paying you in exchange for the information, so there's a transaction there. And if you're not making a charge on the system, you don't have to hand over the information. So in a way, there is already an opt-out happening that we're seeing in some of the cancer information systems. For example, the private cancer treatment centres, no idea how well they're comparing But the thing that protects you there is not the data, it's that the professionals benchmark each other and that there's professional competency and kind of quality systems built into the way they work as well. So it's never just about relying on the technology, but the system already does have quite large opt-outs for certain classes of information. And that frustrates the heck out of the people who are trying to plan things and are trying to figure out whether the rest of the system is performing well.
Sure. Yeah, I've had a request to make sure that you speak through the microphone for people on the net. Ernie.
Yeah, I take the point very much that health is a public good issue, but I also am very conscious of the sensitivity of it. And when the government consolidates all our health information in one place, that doesn't give the government any kind of proprietorship or ownership of it. The government is a sort of a custodian of convenience of it, and we thank them very much for that. Nice to get something back for our taxes, but that does not give them the right to do as they please. So I hear the public good argument, and I think we should not dismiss that lightly, but I also hear very much the sensitivity around some of these research use and that sort of thing. And I think that this is not necessarily an absolute permanent solution that we're seeking here. It's really important that New Zealand does take advantage of the opportunities in front of us, but to me, the sensitivity of a few to the use of their information for research trumps the public good argument. I think that the people who are very sensitive about that, their rights have got to be respected. So my feeling is that we go in very much on the side of caution, lean towards the interests of the people who are very nervous about all this, and if a future generation or a future NetHui says, what the hell, times have changed, we can start to let the brakes off a little, that's fine, but let's not put this program at risk in any way by being a bit too gung-ho about research and openness.
That's a great point, and I think leading on from the point that you made before about just getting on with it and not having too many judder-bars, is that if you do go too fast, then you're £12 billion in the hole, is the UK example. I mean, that wasn't the only reason it fell over, but we talked before about clinicians' involvement in this, and if clinicians don't trust a thing, they won't put information into it to the same degree. If information's not put into it, they'll trust it even less, and so they'll put even less information in. There's sort of a failure spiral that it goes into. There's a very authoritative report by Tricia Greenhall on the UK shared care record, which is very worth looking up if you've got an interest in this area.
I'd like to... Hi.
Sure.
Booming from somewhere. A different direction, possibly. Since we're at NetHui and plugged into the internet, another area of what I think will be developing health questions will be personal sensors that are cloud service provided that measure personal sensor-based qualities of health, heartbeat, diabetes monitoring, a whole bunch of other things that are on the stocks, really, because of powerful micro-miniaturization of sensors and data processing as well. It seems likely that we could contract, if these are not declared health services and are under some form of regulation, then it will be easy for us to even contract abroad, in fact, to have our health monitored, creating data that might fall outside of easy legal frameworks for privacy rights. It cuts across some of the discussion we've had so far, which is very conventional health service with with information systems embedded in them. But potentially, and probably fairly quickly, I believe, we're going to move to a different...
I think that's happening right now. I mean, there's Kaiser Permanente in the US have a lot of home-based stuff. I mean, again, it's the wellness. If you can manage your diabetes by yourself without having to go near a doctor, then you're quits in. Well, we've got just a few minutes to go. Hello.
Thank you.
Oh, yeah.
Yeah, just a couple of points. First of all, the gentleman who had to wait 6 months for his blood test reports, I'd change my GP, especially in New Zealand, where to me that's you go and certainly the practices I'm used to that within a couple of days, if everything's fine, you get a call from the nurse saying it's all fine. So suggest you rethink that one. Second thing, when we were talking about wellness, the health system versus sickness. One of the objectives when the government put in the population-based funding a number of years ago, when they introduced that, was to certainly encourage, through the capped funding scheme, the population, the primary sector, to look after their patients in a more proactive sense. And that's taken time. I don't think it's been as successful as maybe that one perhaps altruistic objective was. And I haven't seen any recent reports on it, but I do think it'd almost be worth looking into that to see how that's worked out. I've certainly seen a change in some practices to be more proactive in getting you to come in for certain checks and so on and whatnot. So that's just in terms of that comment. And then when it comes to the use of the information, maybe what we need to do is to get the researchers and those who are using that information in an aggregated sense or for research or for health improvement sense to do a better job of communicating how they're using it, why they're using it, and what the benefits are, so that there isn't that skepticism. Because as we grow older, we have more expectations. We expect more of the health system. We expect it to fix us. When we have something wrong, we don't expect to have to deal with something for very long on many conditions. And there's a lot more information that has to be collated, gathered, and aggregated in order to allow us to be fixed more frequently, more regularly, and so on. So there perhaps is a communication gap there that could be filled. I'm not suggesting it would assuage the concerns of some of the, that have been expressed here, but perhaps it could go some way towards that. I'm not a researcher, by the way, so I have no vested interest in it.
Yeah, I mean, I think that comes back to the nub of it, and this, unless everybody's got any final comments, this comes back to the nub of it, is that people need to know what's going on, and the job of communicating that accurately, clearly and succinctly is not a simple one. And it's almost like you need to wait for it all to be over so that you can decide what it's all about and then tell people about it. And that's actually not good enough, and it will continue to not be good enough. So that's if there's one, I guess, message I'd want to put across, is that act of communication needs to have a lot of effort put into it. There's this great Mark Twain line, I would have written you a shorter letter, but I didn't have time. And that communicating something in its essence is what needs to happen, because you've already got the trust and the goals are really solid, but there are genuine concerns, and the only way to assuage those is with information. Any final comments? Well, I think that's us for time, so thank you all for hooing.